Hi everyone, and welcome to the Emergency Medicine Clinics podcast. I'm Joanna Gascoigne, the managing editor for the series here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles focused on a central topic. Today, we will be discussing the February 2024 issue on psychiatric and behavioural emergencies. This issue is guest edited by Drs. Eileen Baker of Riverwood Emergency Services Inc. and Catherine Marco of Penn State Health, who are joining me today. Welcome to you both.
Well, thank you for having us on your program and giving us the opportunity to provide a podcast for our book. I'm Dr. Eileen Baker, and I'm with Dr. Catherine Marco today. Dr. Marco, I wanted to discuss the hyperactive delirium and severe agitation chapter with you. Agitated patient is a common challenge for us in the emergency department. We've heard terms such as excited delirium, agitated delirium. What's the best term to use, and how should we manage these patients?
So this is a really important clinical syndrome for emergency physicians to be adept at managing. And the whole concept of delirium with agitation, it's not a new one, even though we talk about the appropriate terminology to use in today's world. So delirium with severe agitation was described as early as the 1800s. And recently, it's received a lot of media attention following some in-custody deaths involving struggles with law enforcement with patients who had this syndrome. ASAP published a white paper back in 2009 that has generated a lot of controversy because people have been concerned that the term excited delirium has been used disproportionately as a cause of death for racial minorities. Recently, in 2021, ASAP adopted a new policy that denounced the term excited delirium as a justification for law enforcement use of excessive force. And this policy also underscored the importance of emergency physician oversight of out-of-hospital and medical emergencies. So the chapter in this book is a great chapter. It was one of my favorites. It explores the whole concept of hyperactive delirium with severe agitation. And the chapter looks at agitation and clinical features associated with agitation, the epidemiology, the pathophysiology, and probably most important for us as emergency physicians, the management. What do we do with patients with hyperactive delirium?
Great. So what should we expect to see clinically with hyperactive delirium?
Well, the features that are commonly associated with hyperactive delirium include excessive physical activity, constant or near constant physical activity. Some people have called this superhuman strength. We might see other clinical features like increased pain tolerance, tachypnea, diaphoresis, hyperthermia, and often these patients fail to respond to police presence. So when we see patients that we're concerned about hyperactive delirium, we want to make sure we're not missing a medical issue. First of all, we want to make sure there's no toxidrome in place. We want to make sure that this is not serotonin syndrome, neuroleptic malignant syndrome, heat-related illness, thyrotoxicosis, or other things that could be causing hyperactivity or delirium.
So how do we manage the patient? What are some of the take-home points the chapter provides?
So the chapter gives us some important information. There's some figures and tables that outline the management of these patients, such as monitoring, staffing considerations, medications that could be used. And the authors conclude in this chapter that the safe and effective agents to use include benzodiazepines, antipsychotics, or ketamine. So it's a great chapter, very helpful to us in emergency medicine.
Dr. Marco, you selected to highlight the schizophrenia chapter. What prompted you to select this to discuss?
Well, the ED management of schizophrenia is challenging. Of course, it's one of the long-standing diagnoses that we've seen in psychiatry for ages, and it is really a challenge for us in emergency medicine. Of course, because we're often treating multiple patients simultaneously, and there are so many challenges dealing with schizophrenic patients.
So why shouldn't we just get a psych consult for all these patients in the emergency department? What is important for the emergency physician to know about schizophrenia?
Well, psychiatry consultation can be an important part of management, but many of us don't have the luxury of having psychiatric consultations available readily in our department. And even if it is available, we need to be adept at the initial management and stabilization of patients with schizophrenia. So we all know that schizophrenia is a clinical syndrome. It involves positive symptoms like hallucinations and delusions, disorganization such as illogical thoughts or speech. We often can recognize these patients right away on presentation to the emergency department by the clinical features. And it often entails noncompliance with medication. Unfortunately, these patients go through a cycle throughout their lives of being appropriately treated, improvement in their clinical condition, and then when they're improved, they may stop taking their medication and end up with exacerbation of symptoms and end up in the emergency department.
So what are some of the emergency department treatments available for schizophrenia?
Well, we have lots of options depending on the severity of the presentation. We may want to give some D2 antagonists. We might want to consider other sedatives that might be indicated to ensure safety of the patient and staff. So we also want to think about non-pharmacologic therapies like verbal de-escalation, social skills training, family therapy, other things that might be accessible to us in our emergency department.
And so what are some of those complications of schizophrenia that we might see?
Well, unfortunately, schizophrenia is often exacerbated by noncompliance and often coexists with substance abuse. Often these patients suffer from other social issues like homelessness, being victims of crime. And so we want to think about all those things when we're evaluating a patient with schizophrenia. What else is going on besides the underlying disorder? Could there be substance abuse? Could there be social issues? What else do we need to address to ensure that the patient is healthy and safe?
Great. Thank you so much, Dr. Marco.
Let's move on now to another chapter. Dr. Baker, you chose pediatric psychiatric emergencies. What prompted you to select this chapter?
Well, I think as we've seen most recently, pediatric psychiatric emergencies are on the rise. I think we're seeing a lot of adolescents and children with thoughts of sadness, hopelessness, and even suicidal thoughts and plans. And this has been shown to have been increasing over the past 10 years. And I think this was even more escalated during the COVID pandemic, which added a lot of additional stressors on both children and their families. There were changes in social interactions with school attendance, meeting up with friends, receiving health care. And even though most of us do not practice designated pediatric emergency departments, we care for children on a daily basis. So some of the challenges we face are even more important or emphasized in pediatric populations, such as boarding, timely psychiatric care, simply because resources are even more stretched in these populations. So this chapter really talks about mental health related visits and how they've changed in recent years. It also provides some principles for evaluating children and teens, because children and teens often have difficulty expressing their feelings. They really haven't gotten to the point where they're used to talking about their feelings. And we often see patients in the emergency department who are experiencing acutely distressing symptoms and can even be acting out in a violent manner. So we want to provide a safe environment for these patients. And also we want to protect our staff members, because even though these are minors, they can be at times very violent and even dangerous. So the chapter also details some assessment tools. It outlines a treatment of aggressive behavior and also provides a summary of some common psychiatric illnesses and how they manifest in the pediatric population, which may be different from the adult population that we're used to.
I just want to take a quick pause here to let our listeners know that they can receive an exclusive discount on the issue we're discussing today by visiting us.elsevierhealth.com/expert.
The next chapter we wanted to highlight is eating disorders. And as an emergency physician, I will admit that I don't see eating disorders on a daily basis in the emergency department. But tell us, why did you select this chapter for discussion?
Well, this is exactly why I did select the chapter. It's actually my favorite chapter. I think the reason that we don't see eating disorders very much is because we're not looking for them. And it's often not something that is discussed much during our residency training. And unless the disease has really progressed to the point of causing medical complications, we are really unlikely to diagnose it. We may note that a patient seems very thin or may have some other psychiatric issues, but not really realize that what we're dealing with is actually an eating disorder. This chapter is divided along the major categories of eating disorders. So we have either the calorie restrictive disorders, such as anorexia nervosa, and then we have the binge or binge purge eating disorders, which include bulimia nervosa, binge eating disorder, and loss of control eating disorder. And it should be noted that within a given episode, these are mutually exclusive diagnoses, but individuals may cycle between the eating disorders. So at one time, someone might be manifesting anorexia nervosa and later on have problems with bulimia. I really enjoy this chapter because it provides a detailed discussion of the definition, the incidence, and presentation of the different eating disorders. It has excellent photographs and clinical exam findings. Could be subtle, but are things that are important for us to recognize. It also shows some excellent CT imaging. What I thought was especially important to highlight is the discussion of the life-threatening condition that anorexia nervosa presents. These, as you may know or recall from medical school, are things like cardiac and electrolyte disorders. There's also endocrine, renal, and GI abnormalities. Something that we may not have learned much about is the complication of actually refeeding a patient once they're admitted or once they've come to our attention that they're severely calorically depleted. It's something that we call superior mesenteric artery syndrome or SMA syndrome. And in this condition, the anorexic patients will lose so much adipose tissue that they actually have lack of adipose tissue within their abdominal cavity, to the point where they have an acute angle takeoff of the SMA from the aorta. So when they do attempt to refeed them enterically, the patient develops severe pain, actually from demand mesenteric ischemia. And this can lead to nausea and vomiting, which obviously defeats the attempt to refeed them. And at times it can require that we put the patient on parenteral nutrition in order to refeed them properly. So I thought that was a very interesting topic, and I not really learned much about that in residency. Now, on the other hand, we have the bulimia and binge eating disorders, and it is noted that these are more common in males than anorexia, and these have a lot of GI symptoms, general weakness, oral complaints, especially because if they're purging, they can have dental decay and develop other types of signs that we should be looking for. The physician must really maintain a high index of suspicion, and that's really the key, is that you won't think of this diagnosis unless you have it in the back of your mind. And so there is a very useful questionnaire that has been developed. If you do have concern that you have a patient with an eating disorder, and it's a quick, easy one, and that's what's the best for emergency physicians, is something that's quick and easy. So these are called the SCOFF questions, SCOFF, and the questions are as follows. Do you make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you recently lost more than over 15 pounds in a 3-month period? Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? And this is a quick, it took me 30 seconds to ask these questions, and that can really give us insight into some of our patients' presentations.
Well, I think we have covered a lot of important topics in this edition on psychiatric emergencies, and we've highlighted a few of them today.
Well, it was a pleasure talking with you about them and a pleasure working with you on this book. We put together really an excellent book, and I encourage our readers to reach out and if they have any questions, to contact us through the publisher, as there's some very important topics that have been raised through our efforts with EMCNA.
Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on the issue we discussed today, focusing on psychiatric and behavioural emergencies, visit us at us.elsevierhealth.com/expert. Emergency Medicine Clinics is available for individual print subscription with accompanying online access, individual online-only access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 60 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter and subscribe to the Emergency Medicine Clinics podcast on Apple Podcasts and the Google Play Store.